February. So getting the funding for whoever provides the services in the most efficient way is one thing, but continuing to make the continuum of care for this population, to make it work through the history of sort of the Lanterman Act, and having families actually care for their children who require a lot of care and have different options, I think, is something that gets tugged at. And this is a population, like a lot of populations, that even at the great amount of $40,000 or $50,000 a year, those families are being pulled apart all the time. So we're going to leave it open. We should have those discussions, but they need to be fairly intense in a brief period of time.
May I add one more thing?
Sure.
Means test is one thing that we think needs to be looked at, but there's share of cost. We've often thought of, why we're not collecting from third-party payers. I think there's a lot of things that we can explore to potentially help the financial stress.
That's a discussion that'd be nice to have in a very intense period, and then hopefully put it behind us and have a model that's sustainable for these folks. Thank you. Any comments, Senator Emerson? Okay. Mr. Rico, thank you. Unless we have any questions or comments, there's no need to come back. But on this item, I think you've heard that we want to have an engagement and help you facilitate those discussions in as quick and a meaningful way as possible. All right. Again, we're holding that open, so thanks to the department. Now we'll go to the Department of Public Health and ask Dr. Chapman to come forward. Yep. We're on page 28 of the agenda. Welcome.
Good afternoon. Dr. Ron Chapman, Director and State Health Officer, Department of Public Health. I want to thank all of the committee staff and CDPH staff for all of the time they've dedicated into working on this very large and complex budget. I'm extremely proud of the work of public health in California this last year. We have a number of great successes to point to. We have record low rates of infant mortality, teenage pregnancy, and tobacco consumption rates. We had one of the largest mass vaccination campaigns of children in the history of California, thanks to great collaboration between local health departments, education, local healthcare systems, and of course the support of the legislature. The success of the pertussis vaccination campaign is clearly evident. We stopped the outbreak in its tracks. And last year, we had no deaths from pertussis, which is a first in 2 decades. The governor's proposed budget proposal, I believe, is prudent, responsible, and transparent. There are some significant proposals that align the department's programs with other departments in anticipation of healthcare reform. And I look forward to continuing to collaborate with the legislature and all of our partners across the state to protect and improve the health of all Californians. At this point, I want to turn it over to my expert professional staff, and again, appreciate the time. Thank you.
Hi there. My name is Maren Klein, and I am with the Center for Environmental Health. And I have here with me Leah Walker, who's the chief of the Division of the Drinking Water and Environmental Management Program. So the agenda includes extensive and very good background on our 3 water issues. And I'm just going to summarize the 3 BCP items that we have for the drinking water program. So let me start with the first item, which is the Safe Drinking Water State Revolving Fund. And this was established in 1996 to provide low-interest loans and grants to drinking water systems for infrastructure improvements to assure compliance with safe drinking water standards. The SRF grant is funded through an annual allocation from the U.S. Environmental Protection Agency. In the current year, that's $86 million, and then there's a 20% state match. We provide loans and grants to public water systems, and in the past, we have executed over $1 billion in funding agreements. The existing BCP is to make permanent the 23 limited-term positions that the program has been operating with. This is to their established program workload, and we want to ensure that the positions are set up permanently to be able to move ongoing projects to public water systems. Any questions on the first item?
Nope. You addressed the questions staff put to you, so I appreciate it. Any public comment on this particular item? This item number 1, Safe Drinking Water State Revolving Fund. No. Okay. So this, again, we're leaving this open, and we'll move to item number 2, renewal of the Proposition 50 limited term positions. You talked about that. Is there any public comment on that? Nope. Did you want to have anything else on that?
No, that's fine.
I think you covered it. Small water system program.
So the small water system program is...
And this is on page 33. Or the questions are on 33, I'm sorry. Go ahead.
Okay, thanks. We're requesting 2 positions, and this is to carry out a regulatory program for small water systems that have been returned to the state from the counties of Marin, San Mateo, and Tuolumne counties. The state statute allows the department to grant primacy to counties to regulate small water systems. A county can choose to stop the primacy delegation and then return the water system back to the state. Currently, we do have 32 counties that do participate in the primacy delegation. What we are requesting is just the resources to be able to provide the additional workload from the 3 counties, and that includes 163 small water systems that have been returned to the state. Any questions on that?
No, I don't think. Any public comment? So on all of the 3 items, you did a wonderful job. Sorry.
Thank you. That's all right.
Coming after some other emotional issues, it's always a little bit difficult. But the recommendation will be to approve all of the requests, so we appreciate it. Since there's no public comment, we'll thank you. And
thank you very much.
The idea will be that this will be back, all of these items that we're leaving open that were recommended for approval will come back to the committee within the next week or so for approval. Thank you. Thank you for the work that you do. That'll take us to... Okay. Next item is California Home Visiting Program, and we'll welcome the appropriate staff. And as you get settled, I want to ask Mr. Kim a question, just to remind him that the legislator and stakeholders are still waiting for the health facility licensing and certification fee report that was due on February 1st. This document is obviously important for the budget discussions, and wonder if you have any update in this regard.
Chairman Desania, Daniel Kim, Chief Deputy Director for CDPH. We're working on that presently, and we hope to get that within the month, earlier rather than later.
So it'll be here by April 1st, is the hope? April Fool's Day?
Our intent is to do that prior to that.
Is there a reason why it wasn't ready as directed on February 1st?
We're looking at a number of different factors.
Well, to keep the spirit of cooperation, just for future notice, we're generally very pleasant people, but we expect people to be able to meet timelines. If you're not able to and there's logical explanation, just let us know.
Yes, sir.
But when there's no explanation, it's hard for us to be very sympathetic, and our job is to hold you to timelines with understanding that sometimes things happen.
Understood. Thank you.
So for future reference, thank you, Mr. Kim. Welcome.
Catherine Camacho. I am the Deputy Director for the Center for Family Health within the Department of Public Health. The first proposal that we have before you is a request to increase our appropriation authority in federal funds by a little over $20 million. And this would go towards continuation of our home visiting program, a new program that was funded under the Health Care Reform Act. And what this additional funding will do is it will allow us to continue and maintain the current local health jurisdiction programs that we currently have running. There were two components to the home visiting funding. The first component was a formula funding that went to everybody. You got a certain amount based on your population. And with those funds, we were able to fund 13 local health jurisdictions. Subsequent to that, the federal government came out with what they called a competitive grant to expand home visiting. California applied for that, and working very closely with our local partners, we were very pleased that we received the absolutely maximum amount available that would have been available to California. With that additional funding, we were able to fund an additional 8 local health jurisdictions. So this proposal would allow us to continue operation of the 21 identified. And they were identified through a needs assessment and assessed for their program readiness. There are some very precise outcome measures that we must deliver to the federal government on a certain time frame. And so it was very important that we selected local health jurisdictions that not only had a very high need, but had the readiness to get started, because what we want to do is make sure that when our health outcomes are reported to the federal government, they are the best that they can be, so that we can not only continue our current level of funding, but perhaps even increase it.
If you could share some of that information on the needs assessment, how big is it?
Well, what we did, because the time frame was very short, and what we had to do was we worked with the locals. We currently do needs assessments. We do an annual state plan that has a lot of data in it. We also then do a 5-year needs assessment that is much more detailed. So what we did to help the counties, is our local partners, is that we pulled information from all of those different data sources, and we sent them to the counties, and that here is your data. Then what they did, it was pretty minimal. I mean, I shouldn't say that because I wasn't the county pulling that together, but because I'm sure it felt like a lot of work. It's a very short time frame, but we minimized it to the extent that we could. We gave them as much as we could, and we had staff available to provide technical assistance. I believe that if you asked our local partners, they would say that we worked very collaboratively with them.
Well, if you could share anything with us electronically, as somebody who likes to read government documents and needs assessments late at night in order to allow me to get a good night's sleep, and also to some attempt to satisfy my curiosity, it'd be interesting to read.
Sure. We had a whole team of epidemiologists who actually headed this, and it was really very professionally done, and we'll be glad to share that.
Sounds like a real hoot and a lot of exciting reading, but
well, it really is.
For people like you and me, we probably enjoy doing it. Okay. Any public comment on this item? Seeing no one, we can move to the next item: maternal, child, and adolescent health reduction in federal funds.
Yes, this is in my center as well. This is a different, home visiting is, there's Title V, but this particular one is the Title V block grant that California has received for a very long time. This proposal is requesting that we reduce our authority by $6.8 million. Different and apart from the home visiting program, has nothing to do with it. And the reduction is required. There's a variety of factors. It was almost a perfect storm. There were several factors that were happening. They all came together at one time, and we found ourselves in a position of having to identify reductions because we had to more closely align our expenditures with the amount of money that we were receiving. And it was a very difficult decision, but what we started with when we determined, where were we going to cut, we first went to our state operations. Now, one of the factors that multiplied here and caused this problem was in 9-10, we eliminated 100% of the general fund. When we eliminated that general fund, we then impacted the county's ability to draw down Title 19 using our general fund. Significant impact to them. So when we had that general fund elimination, we also eliminated state staff at that time. But what is important to remember is that the number of programs that we're doing don't really reduce. Each program is less, but we still have that same responsibility for oversight and technical assistance monitoring. So in addition to the staff that we took in 9-10 to satisfy the elimination of the general fund, at this point, the first thing we did was we turned to the state operations, as difficult as it was, and we took about 30% reduction in our state operations, even though our programming responsibilities are going to remain at this pretty much the same level. We took about over $2 million, about $2.2 million from state operations. What we then did is we worked very closely with our partners again, and we identified reductions that would have the least impact. All of them have an impact, or we wouldn't have been doing the programs, but we identified those that in prioritization of the numbers of people that we were going to impact and the actual impact itself, we prioritized that, and we did that in conjunction with our local partners. And we then also looked at the 5-year needs assessment and the annual state plan, and then what the federal government would consider our core programs. We then went into that task of identifying which programs we were going to be reducing. And if you'd like, I can go through those real quickly about what we did. Is in the in our Adolescent Family Life program, what we reduced in that program was a total of $999,000. Now, what had happened is that 2 of our local programs had indicated to us that they were no longer going to run an AFLP program, and that was for about $750,000. So what we determined is we did not go out to bid to replace those 2 programs. We just kept that $749,000 out of the nearly $1 million that we had to reduce. So then what happened with the rest of it, the reduction to the remaining programs, it will be an impact of about 3%. Then we went to our local MCAH programs. Now that really is the heart and soul, that's the core of our program. We really are required, frankly, by the federal government to keep those programs up and running. So we didn't actually go into the actual formula allocation that goes to the local MCH programs, but what we did is we had some demonstration projects that were over and above. They were separate, and while they were great things to do, when you're prioritizing, we didn't go back out to bid on those either. So that's where we were able to get that money. Then we have a study. We get information data that we use for a variety of documents that we are required to prepare, including the 5-year needs assessment and that annual state plan. And what we did with that is we, instead of charging that directly to Title V, because we do use that information for other programs within the center, we determined that that was an appropriate center expense. So while MCH will still pay a portion of that, it will be it'd be $324,000 less. We then have the California Birth Defects Monitoring Program. That's where we actually collect and review data from birthing hospitals. We do abstractions so that we track birth defects by we have certain reportable conditions, and we do it in specific counties. At some point back in in the days when things were very good, long before I remember, because it's always been bad since I've been here, but we used to do this all the state. And now, we keep having to reduce. But the one thing that we are maintaining, even with this reduction, is we're still maintaining our data collection in the Central Valley. That is the one place that we have, from the beginning of this program until today, have continually been able to collect data. So, what we have to do occasionally is respond to local requests for information. There'll be a situation where someone will say, I think that what's going on in my jurisdiction might indicate a different problem. We then can go in and do some additional data collection and assessment of that. This one was our California Diabetes and Pregnancy Program. And this one they were all difficult, but this one was very difficult because this is a program that we actually eliminated. We didn't reduce it. And what we did is we had affiliates throughout the state serving, approximately 17,000 clients. And if you know the state of affairs in our health, diabetes isn't going down anytime soon that we can see. So this was a very difficult one. But what we did do is we were able to, this year, reduce them by 50%. We then allowed that this year for a ramping down and data collection. We're pulling all of the information we had at the various local programs. We're going to then maintain a state website so that it will be available for everyone, and that we didn't lose all the good work that our local partners had done. So that's what we did with that particular program. We then have the Advanced Practice Nurse Training Program, and that what it does is it does train nurses to reflect linguistic, cultural, and the geographic diversity of California. They train approximately 80 nurses annually, and what this 191,000 represents is approximately a 25% funding reduction, and so they'll be training about 20 fewer nurses. Then we took the state operations in the California Department of Public Health of about $2.2 million. We took another additional $1.2 million from healthcare services. About 30% of our funding goes to healthcare services because there's different categories of funding that we do, and we work closely with healthcare services, and they help meet that 30% requirement of expenditure for children with special healthcare needs. So that is what we're requesting, is a reduction, as tough as it is for us to say that.
And I appreciate your brief overview. Did I miss the Black Infant Health Program? Did you skip over that, or did I miss it?
I believe that I skipped over it, not on purpose. And we are reducing the Black Infant Health Program by $140,000. I apologize for that oversight.
That's okay.
And as you know, that
I thought staff sometimes checks to see if we're paying attention, so I have to.
You had to show her you were really here.
Well, Michelle pays attention.
And what this will do is this will result in about a 3% reduction in the clients that we serve.
Okay.
And as you know, that's a targeted, because we target to the jurisdictions where we've been able to identify 75% of all African American births in California occur.
Yeah, I appreciate that. I know those are tough decisions, but I also appreciate the detail that you were able to explain it for us. That would take us to the next item. Let's see. Women, infant, children, supplemental food. Mm-hmm. I'm sorry. Is there any public comment on the last item? Okay, no one. We can go ahead.
Okay, and the WIC program is also within the Center for Family Health. And I'm just looking for my right notes. Thank you.
Okay.
This is what we asked for is, well, I believe the reason that it's being held open is because we have a new rebate contract. We go out every 3 to 5 years and rebid what we call a rebate contract, and this one is for infant formula. And we had put a placeholder or an alert in our last estimate to say we were going to be rebidding this contract, and we put that in because what the experience in the other states across the nation has been the rebate amounts came back very low, and it actually impacted their expenditure authority for using this funding. And we had put it in thinking that that was what was going to happen. We went out to bid. It's all final, but the new contract will not become effective until August of 2012. And what we saw in California was about a $20 million increase in the rebate. And we were very pleased about that, but it's going to be very important that we get the increase in those rebate funds, because the federal law requires that if there is any money in that rebate fund, you must spend that first before you spend the WIC block grant, the WIC food formula money. And just to give you a little bit of detail is that we have various types of formula products, but the biggest increase that we saw was in our milk-based formula, our basic milk-based formula, where we used to get $11.84 per can of a rebate. That got raised to over $12. $12.02. Yeah. We saw an increase of about 35 cents. And it's going to increase overall by 20. We did not, there is no mechanism right now to put it in. We do anticipate that the May revise, when the May revise is updated, it will be included there.
Okay. Good. Want to protect the WIC program. Any public comment on WIC? No. Okay, we can move forward. Genetic disease testing program, prenatal program, and newborn program.
Yes, that also is under the Center for Family Health. And this proposal is to implement or to add SCID. It's severe combined immune deficiency. It's what people often refer to as the bubble boy disease. Children are born without an immune system. There was a bill that was passed and became effective for us on January 1 of 2012, and it requiring us that we add this. And what we did is we had been involved in a pilot, which is part of the reason that the legislation was prompted, because across the state there weren't really people that were testing for this disease or screening for this disorder. The prevalence rate was thought to be about 1 in 100,000. So in California, we would have expected to see 5 or 6 children annually. And we did a pilot pulling together a variety of partners. Different people contributed to this effort. We contributed some in-kind, our staff. And what we determined was for classic SCID, it was not 1 in 100,000, but it was 1 in 31,000. And when you take a look at the T-cell deficiencies, which this one screen picks them all up, so it's not costing you any more money to identify them, we actually dropped to about 1 in 23,000. And so just because we just enjoy this program so much, I would like to share with you what we found was really pretty startling for the rest of the nation, because we found that we had a very large percentage in the Hispanic community. In classic SCID, 80% of those cases were Hispanic. And if you then take it to classic SCID and the T-cell deficiencies, it was more in the 60s. And that's very important to us because over 50% of the babies born in California are Hispanic. So what we have found is those states and those regions where they have high Hispanic populations, they're clamoring for our data to see what we found. And it was very exciting news, because this is the only condition that we will have in the newborn screening program where we can eliminate the disease. We treat it everywhere else. This, with a bone marrow transplant at a very young age, will literally remove any effect of this disease, and that you don't have to treat the child ever again for this specific disorder. So that's what this proposal is for. It is consistent with the legislation that passed and the fee increase of $9.95 in order to support the program. Except for the Medi-Cal population, it's not generally funded.
It's okay for you to express enthusiasm
we
for the
love
program, especially with the original comments about things have been bad since you got here.
Oh, well, I didn't mean it like that, just money-wise.
I know, that's what I mean. Okay. The recommendation will be to approve it, but we have to hold it open for today because my colleagues aren't here, but we will look forward to approving it. So that takes us to the last 2 items on our agenda: federal special projects, position conversion.
Chairman DeSanya, Dan Kim.
Thank you, ladies.
CDPH. This is about converting staff that are currently in the temp help blanket into permanent positions. In the past, the department has used a temporary help blanket when we've been awarded federal funds. And we weren't quite sure whether those federal funds would be ongoing or not. Over time, we've accumulated a number of federal special projects and other reimbursements from state agencies that receive federal funds. Now, some of these federal funds that we've received and that we pay our staff that are employed through the temp help blanket, we've been receiving them for over 20 years. In the case of the immunization federal grant, we've received that for over 30 years. So consequently, we have a number of full-time civil service employees within our department that are performing ongoing public health functions that are entirely paid with federal funds, but they are not permanent positions. Now, I also want to clarify that the funding for these functions has been appropriated. The legislature reviews this and approves the appropriation annually through the Budget Act. So what we're proposing now is that we just, in the interest of transparency and truth in budgeting, align our budget so that we can show the positions that are actually performing those functions and make it very clear to the public which staff are doing what kind of functions in our department.
We don't want this to catch on, transparency and budgeting. LAO, do you have a comment? Ms. Morgan?
We did review it. We found it initially to be fairly complex, and after digging in, we have no issues to raise with it.
Okay. Interesting. All right. The recommendation will be to approve it when we have our two colleagues back. And that'll take us to the loan from the Childhood Lead Poisoning Prevention Fund. Our last item, if I'm correct.
Yes.
You can do that, Mr. Kim.
I believe the question is, are there any technical issues with taking a loan from the Childhood Lead Fund? And no, there are no technical issues related to a loan.
Finance?
Brandon Innes, Department of Finance. We would concur a $15 million loan out of the fund. There is a healthy reserve there, and so there's no technical issues surrounding it.
Okay. How much is the reserve?
I believe it's $39.5 million at this point.
Make a mental note of that. LAO?
We also concur with no issues to raise.
Okay. Is there any public comment? None. All right. Apologize that we aren't taking more action, but it's more just a process thing, and my colleagues unfortunately had other things to go to that were equally as important. So we appreciate all of your patience with us, and with that, we're adjourned.